while landing with foot in contact with the ground, mostly due to ill-timed neuromuscular firing of the structures around the knee, causing translation of the tibia on the femur. If you can see this, it is the same person tried to, you should know that a very typical way to understand that the ACL is injured or there is a knee injury which is very devastating is the grab the knee kind of a response from the player on the field. If you can see in this picture, as he was landing, the player started to hold his knee. See, look at that. Grab the knee. So it's a very important sign. If you're a physio who is with a team sport, or you're watching a sport, and you're monitoring that, and you want to know what kind of a injury would be. If something like this happened, where the player try and reaches for the knee to grab it, you should mostly think it is the ACL injury. Hyperextension is another contact. It can happen very much when you land, or when you're landing, as you can see in football or in cricket, where this fielder was trying to stop the ball, but look at the hyperextension which has happened into his knee. And similarly, this is Latan Abramovich, who was playing for United when he injured his ACL upon landing, and this was an hyperextension kind of a mechanism, which hyperextended injury with foot in contact with the ground. See, it's always the foot is in contact with the ground, and the hyperextension happens at the knee, and that's when ACL is the most vulnerable and it would get injured. And the third kind of mechanism, you saw the first mechanism, which is a contact injury. You saw the second mechanism, which is the non-contact injury. Non-contact is basically the most commonest injury you see. Sorry.
I think someone is disturbing, so everyone please mute yourself.
Am I the host, Doc, right now?
Well, not as of now, because I'm admitting.
Okay, Doc. So if you can mute everybody, will be better. No, yeah. But I'll get also muted, right then.
Yes, this is it. Yeah, please. So Vaibhav, you have to unmute yourself.
All right.
Yeah, please.
Got that. Okay. So sorry, let me get back to the previous slide again. Mechanism of injury, indirect contact is the third way of injuring an ACL. When a person or object strikes a part of the body other than the knee itself, causing excessive forces to be transferred through the knee. Okay, so it is not a direct contact with the knee, but an indirect contact, where the contact is in any other part of the body, which forces the knees to be in an awkward angle, getting into an hyperextended position, or possibly the valgus stress, and the ACL can get vulnerable and injured in that kind of indirect contact. Let's come across a few facts. As I said, non-contact are 70 to 85%. Walden et al. In 2015 found out that 70 to 85% of the injuries are non-contact injuries. Peak incidence of females is in between 14 to 18 years of age, and for the males, it's 90 to 95 years of age. Contact ACL injuries, 15 to 30% of all the ACL injuries. Females are 2 to 8 times at a greater risk of tearing their ACLs. Now, why are the females at a greater risk of the injury? We will discuss that a little bit later. Odds of rupturing an ACL, a normal ACL, rupturing that is 1 into 1,750 ACLs. 1 to 1,750 individuals, an ACL could be ruptured, but odds of re-injuring an ACL reconstructed ACL rupturing is 1 into 33. 33 ACL which have happened, reconstructions have happened, there is a chance of injury. One of them will definitely get re-injured. So the re-injury rates are pretty high, and that's where we as physios come into the picture to see to that the return to sport is very systematic, and it's understood that the rehab is proper, and we don't rush them to their back to their sports, so the re-injury rates could be reduced. So that's the most challenging part of the rehab today in today's world. Uh, okay, next is, yeah. So the incidence, can somebody just stop drawing those lines on the screen? Somebody's doing that. I'm so sorry for that.
Please don't write on the screen, everyone, please.
Okay, incidence, as I said, there are around 100,000 to 300,000 over the whole world. Over 2 million ACL tears a year, about 80 per 1,000 citizens was found out in a study in the USA. Greatest prevalence is in young females, as I said, 14 to 18 years of age. 3% of amateur athletes injure their ACLs, but as high as 15. Can you please mute yourself? Thank you. So greatest prevalence, as I said, is in the young females, 14 to 18 years of age, and 3% of amateur athletes injure their ACLs, but 15% of elite athletes. So the ACL is very much common in the elite athletes. It's because possibly it's because of the competitiveness, it's because of the professionalism what they have, and and the kind of opponents they have, possibly the most fearsome and the most competitive opponents also they have. So that's why the rates in an elite athlete is much more than an amateur athlete. Non-contact injuries 3 to 5 times more common in female athletes. So as I said, the females, there's a lot of work going on about the female athletes. What is exactly, why is it happening? So it says it's because of the hormonal changes. It's because of the hormone relaxin, which is possibly more into the females, or it is the biomechanical issues, which because of the wider pelvis and the more femoral adduction or the femoral retroversion angle. There are a lot of things coming out of why do the female athletes get more injured than the males, in particularly ACL injuries. Yeah, this rate decreases as female athletes mature, but still disproportional at a professional level, as I said. Okay, the next one. What are the treatment options? So we have seen the mechanism, we saw the prevalence, we saw the incidence. So what are the treatment options we have? Definitely, there is a non-operative way of dealing with the ACL injuries, which is not very well tolerated. There is a repair which could be done, which is again not very well advanced. These days, they are trying to repair an ACL in the latest studies, but still not a very great outcomes from that. Yes, the better outcomes are the reconstructions. The reconstructions of an ACL. There are 2 types of reconstructions, with an allograft versus an autograft. Autograft are the hamstring tendons, bone, patellar bone, BPTB, or the latest, which is the quadriceps tendon. So you have to understand our rehab definitely changes when we know what kind of a tendon is used, what kind of a graft is used. Okay, autograft is basically taken from yourself. Allograft possibly from a cadaver, or basically the cadaver. So reconstruction type, non-anatomic versus anatomic. There are types of reconstructions. Non-anatomic is very critical. Good anterior-posterior stability, rotational stability is compromised, and a graft failure and tunnel placement. This was initially, they started with a non-anatomic site where they drilled the tunnel for the graft placement, other than the normal anatomy of the insertion of the ACL onto the tibia. So when they did that, in studies, they have found out that the rotational stability was compromised in that, and that's why the graft very much failed. After that, after a lot of studies and after a lot of trials, what they did, anatomic grafting and anatomic graft placement was done, restoring the native ACL footprint to recreate native functional kinematics was the key for a good rehab and an early return to sport. So it's definitely, you have to understand that reconstruction is not one size fits all. So the size of the graft could change. It depends on what kind of a size it has to be taken. It is much more surgical way. I'm not going to go into details of that, but you should understand basically if it is a non-anatomic placement of the tunnel, there may be failure of the graft. So usually these days they go on for the anatomic placement of the tunnel in the surgical way. Double bundle versus single bundle. These are the facts. These are the terms you should just know, because what is going to happen is when you understand, when a patient is referred to you as physios, you should understand what is a double bundle surgery, what is a single bundle surgery, and how it can differ, and how we can probably change our rehab accordingly. Double bundle graft is to reconstruct both anteromedial and the posterolateral bundles. Number of studies demonstrate that the biomechanical promise of the double bundle reconstruction fails to translate into clinical significance and may predispose the graft to impingement and excessive tension through the posterolateral bundle during knee extension, resulting early graft rupture or attenuation. Biomechanical studies demonstrate that anatomical single bundle grafts tension either maximally in extension or submaximally at 20 to 30 degrees of flexion most closely reproduce native knee kinematics. Okay, as such, double bundle reconstruction has lost its momentum in favor of the anatomic single bundle reconstruction. So the idea of telling you this is basically the ACL, they're trying to reconstruct the ACL as it was naturally there, because it has been torn. So we want to get it back to the same way as it was exactly. So anatomic placement, single bundle reconstruction, that is what they are looking at, and they have found success in that. Graft type, selection based on the patient age, skeletal maturity, and the activity level. As I said, there are 3 types of grafts: bone, patellar tendon bone, hamstrings, and the quadriceps tendon. Autograft considered in the young active patients. Non-irridated allograft has been the choice in older or non-active patients. In the latest studies have shown that in middle-aged recreational activity patients, acceptable and equivalent to autograft, strict rehabilitation parameters for 8 to 12 months for ligamentization before return to recreational activity. So if you have the autograft, but in the middle-aged patient, it says strict rehabilitation parameters have to be followed for 8 to 12 months before they really return to their recreational or sporting activities. Just a word on the quadriceps autograft, the graft of the future, as they are calling it these days. Both patellar tendon bone and hamstring autografts have long been considered the main graft choices for the young and active patients. Bone patellar tendon bone gives donor site morbidity, anterior knee pain. That's the problem. So if patellar tendon bone graft is used in an ACL, there are chances of the anterior knee pain. Your rehab would differ because of the anterior knee pain, because you cannot load the knee so much at that particular time. So probably it gets delayed in the rehab, but still people are doing it. There are studies going on in different parts of the world regarding how do we get the most out of the bone patellar tendon bone graft, and the rehab techniques are changing, rehab styles are changing, rehab ways are changing. Hamstring tendon, equivalent function, less donor site morbidity, but the drawback is increased laxity and graft failure rate. Quadriceps tendon used historically as a revision. Initially, the quadriceps tendon has been used as a revision surgery for the failed ACLs, for the failed ACLRs, basically. But now a choice as good strength, less donor side morbidity. As per Fisher, quadriceps is an antagonist to ACL. Slightly impaired function of the muscle may protect the ACL graft. That's what they're trying to claim. So slightly impaired because it's an antagonist muscle to the ACL. Because as you know, what is the function of the ACL? As we know, the function of the ACL is anterior translation of the femur, of the tibia on the femur. So if and the quadriceps give an antagonist action to it. So if there is a slightly impaired function, it will protect the ACL graft. That's what they're claiming. That's why they are looking at using the quadriceps tendon graft. Demonstrate significantly higher hamstring to quadriceps ratio than the hamstring tendon grafts within 1 year after the surgery. Studies have shown that they're demonstrating high hamstring to quadriceps ratio. A recent systematic review concludes that the use of quadriceps tendon for ACLR is safe, reproducible, and versatile. So, resurgence of primary anterior cruciate ligament. Historically, poor outcomes have been associated with primary ACL repair. Okay, so recently there has been an increasing interest in ACL preservation as an option to perhaps better restore the native ACL anatomy. What I was talking about, they're trying to be as close as to the native anatomy, what was present before the injury. So they are trying to restore the native anatomy, biomechanics, and neurosensory function. Primary repair aims to preserve the native ACL's inherent healing capacity, proprioceptive function, and the knee kinematics. So usually, as long as they try to retrieve the stump of the ACL, and if the reconstruction is done with one of the grafts, as we discussed before, they try to retrieve and have the stump as much as possible, as much of the stump to preserve it and use it in the repair again. Primary ACL repair may be considered in the setting of proximal tears with good tissue quality, whereas ACLR remains the preferred technique in non-proximal tears and those concomitant ligament injuries, limiting early ACL focused rehabilitation or those with poor tissue quality. Just for physios to just know the term, what exactly are the more terms about? There are the ways of internal bracing which is happening. The ways ACL has been evolved, the ACL reconstruction has evolved. The surgeons are doing internal bracing these days for extra stability of the graft. There is anterolateral ligament, which is being and technique which is being done. There are biologic agents like the PRP and the stem cell, which are being used, but they definitely have a very limited evidence. So not very much common to use the PRP and the stem cell. But yes, internal bracing and anterolateral ligament repair or the reconstruction is a very much way forward ahead these days to have a good stability for the ACL. Contributing factors, as we said, possibly relative stronger quadriceps to hamstring development, aiding to the anterior translation forces. Okay, so if there is a difference between the quads and hams ratio, initially it was said the quads ratio has to be 2 times more than the hams ratio, but possibly because of that kind of a initial way of doing that, of a difference in ratio, 2:1 or something it was initially when, according to the literature, the anterior translation forces were more, and it made more vulnerable for ACL to give away. So it is better to have a good 1:1 ratio these days in the strength of quadriceps to the hamstrings. Age 60% children with hemarthrosis have ACL tear. You should understand that it is whenever there is a child with a hemarthrosis, it's 60% chances that he would have an ACL tear. 15 to 44 years main age group, less than 19 years is larger risk. More males more than females. Notch size, narrow femoral intercondylar notch, increased risk are the other anatomical uh, parts. So that's why these days surgeons do the notchplasty also if the notch size of the femoral anticondylar notch is an increased risk. Prognosis definitely depends on patients' requirements of future knee function and whether they decide to have a surgical repair or not. Patient must decide whether they are prepared to reduce their activity level. Post ACL reconstruction, graft at maximum strength at the time of the surgery. At the time of the surgery, 6 to 12 weeks, graft strength is at its weakest. So you have to understand how your rehab exercises are placed and what kind of an exercise is to be done at what stage of the rehab is very important. And definitely with the surgeon's consent with this and taking into confidence with the surgical team is the most important way to progress on an ACL rehab. At 9 months, graft begins to regain its initial strength due to the synovial growth and vascularization.
Yeah, Vaibhav, sorry. Please continue.
No problem, that's okay. So that's about the prognosis. So as we go ahead with the management now, to go conservative or to go undergo surgical reconstruction is a commonly faced scenario. Depends on the limitations of the activities of daily living and the participation in a low risk sport. Avoidance of twisting and pivoting activities increases the likelihood of recurrent subluxation. Assessment of Vikas Patel, could you please,
Please mute yourself. You're
Vikas,
disturbing, you're disturbing again and again. Vikas Patel, please mute yourself. Yeah, Vaibhav, please.
thank you, no problem. So assessment for a conservative management approach was done by Colt and Mackler in 2003. So they had a criteria to decide if we should go with the conservative management or go for the ACLR. ACLR. No more than one episode of buckling since the onset of injury. That was their criteria, first criteria. Score at least 80% on the timed hop test. Score at least 80% on the knee outcome survey ADL scale, and score 60% on the global rating scale. So these are the various scales they used, and the hop test was performed, and they should be 80% to the normal limb. And the episode there should be only one episode of buckling since the onset of the injury, and when it is decided to undergo, when it is the time for decision making to either go. That was one of the studies presented then. Management. Otherwise, conservative management should only occur when there is no other concomitant ligamentous injury more than grade 1, no repairable meniscal injury, or no full thickness cartilage tearing. In elite athlete, ACL repair is absolutely required, and even a trial period of conservative rehabilitation is probably just delaying the complete recovery process. That's what they say. So if you're dealing with an elite athlete, you definitely should consider the ACL repair, and that's what the surgeons these days do. I'm sure surgeons Dr. Vikram would have spoken to you about it, all of them in his lecture yesterday. Without surgical repair, the risk of secondary meniscal or articular cartilage injuries is high. 70% of untreated patients develop radiographic evidence of arthrosis after 10 years. So coming back, when we look at the acute management, management, it is a very first aid. It is basically this is the latest acronym what is come across as called peace and love. The P stands for the protection first, elevation, avoid anti-inflammatories, compression, and education. So protection is very, very important. So once you see on the field that the ACL is injured, it is better to protect it and get the offload it completely. There should be no load onto that particular limb. And the protection is the first uh, way to you can protect, and you cannot further damage the injured ACL. Of course, elevation as much as possible as you get him out of the field. He or she who's has had an ACL injury, we definitely don't try and give the anti-inflammatories because it hampers the natural healing process. The anti-inflammatories have the medications have come into the picture of it's been said that they hamper the natural healing process. So it's better to avoid them. You definitely compress for the swelling to reduce, or the effusion to reduce. And education about what has happened and how they should be taking care of this particular injured limb is very, very, very important. Okay, the load, it has to be a very optimal load. It should not be that the load has to be there, but a very optimal load. As and when you progress onto the on the pain and the swelling and the initial and inflammatory issues, the load has to be graded accordingly. There should be a lot of optimism about the management ahead. The vascularization to be increased, so a normal exercises which are not going to put the um, ACL into a jeopardy, or it is not going to load it more to injure it further. You can do those kind of an exercises. So that's why it will help the vascularization, as well as it will help a little bit of movement, which will help them to be optimistic about going further in the management. Pre-op rehab, very important phase. Begin rehabilitation before surgery when possible. Aim is to reduce swelling, inflammation, and pain, restore normal range of motion, normalize gait, and prevent muscle atrophy prior to the surgery. Full motion is restored before the surgery to reduce the risk of post-operative arthrofibrosis. Patient education, as I said, a critical aspect of preoperative rehabilitation. A patient should be addressed when they have decided they're undergoing an ACLR. You have to understand that the prehab period or the pre-op rehab period is very important for them. So uh, if they are educated, and this is where this is, this is where the patient has to be made to understand how long is this rehab period going to be, what are the ways it has to be. He should be assured that he can get back to his sport, but not before 9 to 12 months, because a lot of studies have shown somebody who have rushed back for the return to sport have landed up in a re-injuring the ACL. So that's why this kind of education is very, very important in this phase of what they should expect in the first phase, in the second phase, and in the return to sports phase, or the advanced phase and the return to sports phase of their rehabilitation. Usually 21 days is adequate, but it can go, the prehab period can go for several weeks. But 21 days is what the studies have shown, that a good prehab of 21 days will help the outcomes in the rehab part are much more better when they do the prehab of 21 days. Studies have shown pre-op helps, pre-op rehab helps post-op progression more easily, especially in earlier phases for the range of motion. So it is a very important aspect of having a good pre-op rehab period. Yes, and that brings us to the principles of ACL rehabilitation. So what are the principles? The principles are, you should have a full passive knee extension in the first phase as you do the rehab. restore patellar mobility, reduce post-operative inflammation, range of motion is to be achieved, re-establish voluntary contraction of quadriceps, um, restore neuromuscular control, gradually increase applied loads, and progress to sport-specific training. So full passive and active knee extension. Extension loss results in abnormal joint arthrokinematics at both the tibiofemoral and the patellofemoral joints, which can land up with issues with the anterior knee pain and so on and so forth ahead. So low load, prolonged stretching and calf stretching is what has to be started in the earliest phase of the rehab. I mean immediately post-op, you should we should concentrate on achieving that knee extension actively and as well as passively. We're not talking about hyperextension, mind you, it is the knee extension. Okay, so prone terminal knee extension is one of the good exercises to achieve this. It's basically, I would show you a video of how to do a prone terminal knee extension later. Possibly I had it here. I don't see it right now, but it's a very good exercise so that in the initial phase to get the quadriceps control and to get the extension lag out of the way. This particular exercise is very important. Restore patellar mobility. It has been shown the loss of patellar mobility, referred as an infrapatellar contracture syndrome, results in the range of motion complications and difficulty in activating the quadriceps. So mobilizations are performed in the medial lateral and the superior inferior directions of the patella. Very important to start as early into the first phase of rehab. Inferior guided patellofemoral joint mobilization are utilized to encourage gains in knee flexion also. So if you give an inferior glide to the patella, it has shown the knee flexion ranges will improve accordingly, because it has been shown to be doing that. Reduce post-operative inflammation. Controlling post-operative effusion assists in discouraging quadriceps innervation. It has been always said, see there, the post-operative effusion, even a small amount of effusion in the knee shuts down your quadriceps activity. Even they say even a 1 milliliter of effusion in the knee joint will reduce the girth of the quadricep muscle by around 1 centimeter. So that's what the ratios are, and that's what these studies have shown. So Spencer et al. Identified that mechanoreceptors in the joint capsule respond to changes in tension and in turn inhibit motor nerves supplying the quadriceps muscles. Therapeutic interventions utilized include the use of commercial cold and compression device like this. You can see in the picture, the Game Ready. It's a very good device where there is a kneecap, there is a compression and the cold, which is both happening together. So it is very important to use this in the post-operative phase to reduce inflammation, which will help the quadriceps to function better. Range of motion exercises. Yes, range of motion, range of flexion goals to 120 degrees should be met 4 weeks following the surgery, and full symmetrical flexion achieved by 12 weeks after the ACLR. Treatment strategies employed to further progress gains in flexion. Range of motion include wall slides. You can do the wall slides. You do active assisted range of motion sitting on a step, or sitting or on a step. Okay, and 1/2 moon movement on a stationary bicycle. As you can see, 1/2 moon on the one-sided kind of, I mean, you don't do the other side, but one-sided knee flexion exercise. You can start in the earlier range, only one pedal kind of a thing. That's why it's called 1/2 moon movement on a stationary bicycle. Quadricep stretching on a of the side of a plinth, as you can see in this picture here. I'm sorry. This is the 1/2 moon movement of a stationary bicycle as it has been done. only on the one side. This is the bedside knee flexion, which you can help the other knee could be used to assist in the knee flexion movement. Other assistance by the side of the plinth, you can do it eventually by the side of the plinth. You can do it with a stretch band or with a band with a belt, which could be used in assisting the knee flexion. Eventually, in a prone position is introduced to the patient's program. First, initially start um, with the supine by the side of the plinth, and then introduce it back in prone position also. Soft tissue massages can be of particular benefit throughout the progression to restore the full symmetrical flexion range of motion. So soft tissue massages, your hands-on treatment are the treatments which needs to be started at this stage, so that the quadriceps are are very well conditioned with the soft tissue, where the fascia over the quadriceps is not contracted, and you release that fascia so that you can get a good range of motion with that. Re-establishing voluntary quadriceps control, electrical muscle stimulation. EMS has found out to be one of the best ways to do to re-establish voluntary quadriceps contraction. It has got a lot of evidence in today's world. So electrical muscle stimulation and biofeedback are often incorporated into therapeutic exercises to facilitate and the active contraction of the quadriceps musculature, which was basically described by Kim and his team. Neuromuscular electrical stimulation combined with exercise was more efficient than exercise alone to improve quadriceps strength after ACL surgery. So it is kind of more of a biofeedback kind of a rehabilitation, where you basically do the contraction of the muscle with the stimulation what you receive from the EMS, and it will help. That has been found out to be much more effective than on exercise alone. Neuromuscular training. Neuromuscular training was first introduced by Ryberg in 2001. ACL contains mechanoreceptors and directly influences neuromuscular control of the knee. ACL deficient knee results in loss of proprioception, postural control, and recruitment patterns. So vital part of prevention, prehab, and throughout the post-op phase, and needs to be maintained indefinitely to prevent re-rupture or tear of the contralateral knee. So it is a very important phase of your rehab, the neuromuscular training. So this training has to be very well done, and it becomes a very vital part, as it is said there, for prevention, or for even in prehab phase you can start with that. Then throughout the post phase, and needs to be maintained indefinitely till the player or the person gets back to his particular sport. When do we start? We start as soon as walking full weight bearing is allowed, is there, with gentle non-complex exercise using minimal weight, and developing from static to dynamic balance training and plyometric exercises into agility training and sport specific exercises. Just a second, just give me a second. I'm sorry, guys. Just something went wrong here.
Yeah, no problem, Vaibhav. We are here.
Sorry. Some. Just a minute. Huh?
Yeah, yeah, sure.
I don't know where that.
So, guys, meantime, Weber fixes his computer's problem. Is there any question from your side?
Yes, please. I mean, that will be important also. We
Yeah.
let us make it more interactive because I'm just only speaking and nobody else.
Yeah.
It'll be nice. Yeah, be back.
So,
Hey, what's happening?
so Weber, you're trying to share your screen or what exactly?
Yes, I am. Now it's not sharing. Can't you see my screen now?
No.
Just a minute. Something.
So, you can redo that sharing. Vikas, Mr. Vikas, please take care.
Yeah.
Mr. Vikas Patel, please mute yourself.
Yeah. So we were speaking about the. Can everybody see my screen now?
Yeah, this is visible.
Yeah. Okay. Any questions there till now? I can take those right now.
Yeah, Weber, there are a few in the chat box. So if you can see them.
Oh, I'll just check them. Just a second.
So one is this can be perform a spatial test in acute suspected cases, or else it may worsen the injury.
Um, Melvin is asking me question. Yeah,
Yeah.
can a special test be performed in acute suspected cases? Yes, definitely. That is the way you are going to confirm if it's an ACL injury. And what will be the special test? I mean, I'm sure it was covered in in the program in the lecture series before. But yes, Lockman test is the one of the most go-to test which can be performed, and it is not going to worsen the injury definitely, but we need to get a feel of we need to understand that there is an ACL, it's an ACL deficient knee if the Lachman test is positive. So accordingly we can act upon, because that's the go-to test right now, the most reliable and the most valid test for ACL is the Lockman test. Yes, it will not worsen the injury, don't worry, but you have to do it. It will be difficult to perform that in an acute case because of the swelling and the more because of the effusion, the swelling of the knee, and other, if there is and because of the pain also. So if it is not possible to perform there and there itself, possibly you can wait for the swelling and the pain to reduce, and then you can perform the same test, confirm your clinical diagnosis. Um, as you said, in one pre-op rehab, we need attend full range of motion, but due to the swelling and spasm of the muscles, how to attend? That's how it is, Latika. You have to attend. That's why surgeons these days don't go for an ACL reconstruction immediately. Dr. Vikram would second that. My thought on that day, it is not that you're injuring the ACL today and tomorrow it will be reconstructed. So you get time, and those 21 days of time of pre-op rehab will help to get us the range of motion back, to attain the full range of motion. I mean, usually surgeons prefer these days to have a full range of motion before they really reconstruct an ACL, so that the post-op rehab is much more easier. You're asking me how to attain it. There are various ways. The normal range of motion exercises, what we do, will be possible to be done. Soft tissue releases, what I talked about, to start the range of motion exercises on the bedside, on the bicycle, on the active assisted range of motion exercises, and then probably prone knee bendings by the side of the plinth, using the soft tissue release techniques. This will be These will be the most important things to attain the full range of motion. Of course, it has to be seen that it is not very painful and unpleasant to the patient or the player, but it can be definitely done progressively with a
And
gradual progression.
one more question from Vishal Saxena.
Yeah.
He wants to know what is the criteria for selection of patient for surgery or for rehabilitation?
Yes, Vishal, surgery or rehabilitation, as I said, there was this criteria, what I talked about. There was a study by Mackler in 2003, where he did that, they come out with that there is no episode of buckling, not more than one episode of buckling when he's seeing the patient, and there should be an 80% um, 80% distance covered on the hop test, absolutely on the 80% score on the WHO score, which is the knee outcome score, and the global rating scale of 60%. So these are the criteria which I explained earlier in my presentation. I probably would show you that later on if you ask.
And Shabnam Bano wants to know, is kneeling a problem after ACL reconstruction using BPTB graft?
There is an issue with the BPTB graft. That's why these are the issues which come across when a BPTB graft is used, a bone patellar tendon bone graft is used. That's why it's not it's not a very common graft which is being used at these days for ACL reconstruction. So that's the reason. I mean, there is a problem with the anterior knee pain, with kneeling. Uh, it's not a permanent problem, but if you're asking me if it is a permanent problem, no, it is not a permanent problem. They end up very beautifully. Today also a lot of footballers are going through BPTB itself. So actually, if you're asking me if it is a permanent issue, no, it is not a permanent issue. But yes, in that rehab phase, we can get different times of rehab. The rehab probably will be a little bit delayed because of the anterior knee pain and because of the pain in front of the knees, and the patient cannot kneel down.
So, well, Shabnam, I think this is clear to you. Actually, bone patellar bone graft is a very strong graft. And when we started arthroscopy, we started with bone patellar bone, then gradually shifted to hamstring. But even as of now, the proprioception and the healing is better as compared to the hamstring in the bone patellar bone graft. But
Yes.
sometimes the graft site morbidity becomes the issue in initial stages. So, as Vaibhav told you, so I think there's no question further. And Vaibhav, please continue. Yeah.
Yes. Thank you. So as I said, the neuromuscular training should start as soon as walking is full weight bearing with gentle non-complex exercise using minimal weight and developing from static to dynamic balance training and plyometric exercises into agility training and sports specific exercises going ahead. So these are the ways neuromuscular training exercises are done. These are very commonly done. You can see how these are kind of prevention exercises. Also, they use it as a prevention exercises in soccer proprioception training. So you do use a lot of balance and unbalance, the balance kind of equipments like the Bosu ball or the trampoline, where there's a lot of challenges for the knee or the ankle per se, to which produces a lot of challenges. You use it with the ball. We use it very sports specifically. These are the various drills where it's an unstable surface that you work on, which actually improves your neuromuscular function, and that helps. So as you can see in that player, where there is a resistance pulled from behind and he's going on an unstable surface to kick the ball, he's jumping on an unstable surface to kick the ball. These are the various ways the soccer players train themselves so that they can prevent the injuries like ACL or any ankle ligament injuries also are prevented by doing these kind of any lower limb ligament injuries actually. These are, this is for the upper limb, of course, the neuromuscular training. So this is very important. Jumping, heading and landing on an unstable surface, ensure your landing is proper. It's a soft landing. You can see they're landing on their toes. It is not necessarily they land on their heels completely. They look into the various challenges of a steps, run through, land, kick. So this was about neuromuscular training, how it can be progressed. Okay. After the neuromuscular training, how gradually you can increase applied loads, close kinetic chain exercises, including leg press and squats, inside a pain-free arc or motion are introduced, as these activities have been shown to minimize stress to the ACL. Limited evidence now demonstrates that open kinetic chain exercises inside 90 to 0 degrees arc of motion may not compromise graft laxity. Initially, there was a notion that you cannot do open chain kinematic exercises at all. Uh, but the latest limited, there's a limited evidence which demonstrates that if you do it in the inner range, which is only from 0 to 90 degrees and not beyond 90 or more than that, it does not really compromise the laxity. So this is called the inner range quadriceps extension exercise. It does give a good activation of the quadricep muscle. So open kinematic chain exercises progression begins with multi-angle quadriceps isometrics inside 90 to 40 degrees arc of motion. Strong evidence both closed chain and open chain exercises can be used to regain quad strength. It is not only about the closed chain these days. So just a word about how open chain versus closed chain kinematic exercises. Open chain exercises have been strictly avoided since the first ACLR was done. Isokinetics, especially when Cybex first came out, was the only open chain exercise permissible. You know, isokinetic strength testing was the only open chain kinetic exercise was possible. So all of us really got rid of our knee extension machines because of the effects of the anterior knee pain because of this. But at the same time, the closed chain kinetic exercises reduced anterior tibial displacement, which occurs with an isolated open chain quadricep contraction. The primary aim for this review was to determine, this study which was done open versus closed, was to determine whether open kinetic chain exercise, quadricep exercises results in differences in interior laxity when compared to the closed chain exercises at any time point following an ACLR. The secondary aim was to determine whether there are differences in the strength, function, quality of life, adverse events with open kinematic chain quadricep exercises when compared to the closed at any time. So these were the two aims of the study of open versus closed kinetic chain. So what was found out? Early versus late reduction, slight increase in laxity, especially in the hamstring group. No difference in strength was found when early started. No difference in patient-reported functional outcomes. Late, when we started it late, no real difference in laxity, no difference in strength at short-term, late-term follow-up, and no difference in patients' reported fine functional outcomes. Conclusion, early introduction of open kinematic chain has a limited to moderate effect on anterior tibial laxity, but it also only had a limited to moderate effect on strength, patient-reported functions, or physical functions. Adverse effects poorly reported, so this hasn't really answered the question of the safety of the early implementation of OKC exercises. The hamstring graft may potentially be vulnerable to laxity than the patellar graft, but this conclusion is based on a very limited evidence what has come across in the literature. Not enough studies on women who we know have been found to have increased laxity when hamstrings are used, and so may be more vulnerable to increased laxity with an early open chain kinematic exercise. So it's not a very clear conclusion, but yes, if you use it in the inner range, there will be no problem to the graft. So then the next step is progress to sport-specific training. After 2 to 3 months post-op, if range of motion is within normal limits and sufficient strength is demonstrated via pain-free 8-inch step down without deviation, a running program is started. You understand what is a 8-inch step down without deviation? All right. So if that is cleared, that's the time when you can really start the running. The running program is progressed with an emphasis on speed over shorter distances versus slower distances long running. Plyometric training is then incorporated only if full range of motion and adequate strength base and flexibility is demonstrated. Agility and deceleratory training are important interventions to include in the later phases of rehabilitation in preparation to the return to sport. I'm just going to briefly take you how the rehab has changed from the 80s to the 90s to right now in the 2010s. In the 80s, as you can see, 0 to 3 weeks, hinge knee brace, 30 to 60 degrees only motion was allowed, CPM within this range of motion, 0 to 90 degrees passively was done, and total weight bearing. As the evidence increased flexion range by 10 degrees per week from 3 to 6 weeks, and so on and so forth. CPM within this ROM was allowed and was done actually. Static quadriceps, SLR, hip abduction and extension, and partial weight bearing in between 3 to 6 weeks. Brace off and wean off crutches. So as you can see, this was what was followed in the 1980s. Progressive resistance training, still avoiding terminal 30 degrees of extension was still avoided, and cycling and isokinetic rehabilitation was the only way you used to do that. In 1990s, what happened? Weight bearing as tolerated in rigid knee immobilizer, locked into full extension. CPM was introduced, passive range of motion for focusing on full extension. That's when in the 90s they started to focus on the full extension. Prone hangs and torture pillow, all these things were done. In the second and third week, the brace was weaned off. After 10 weeks, full range of motion was achieved. We're trying to achieve, sorry. And isokinetic evaluation and sport-specific drills were started early in 1990s, but the failure rates were higher. So why the change? Found a non-compliant patient were doing better than the compliant patients, started weight bearing earlier, returned to ADLs. So it was not very clear in the 80s and 90s how to progress about it. They returned, a few who didn't do the rehab also returned to the ADLs earlier. Fewer complications such as anterior knee pain and loss of terminal extension. Other reasons for the accelerated protocol, which was in the 1990s, was arthroscopic surgery had come into the picture, bone tendon bone graft was there, semitendinous and gracilis, and improvements of fixators, introduction of closed chain kinetic exercises, better understanding of tissue healing was there by the physios as well as the surgeons. And so that's why in 2010, the surgical techniques still further improved. Like the fixators were there, doing more anatomically correct placement of the ACL footprint. Double bundle versus single bundle techniques were used. There was an anterior ALL repair also was done. Internal bracing was introduced. Better understanding of the healing process, physiotherapy and rehabilitation processes were improved, and addressing causes of injury was more focused. That's why now, again, it's gone to a very more conservative, because we've got back to evidence-based protocol, criteria-driven rather than time, better understanding of tissue healing. Load management ensures we load the new ligament appropriately, ensure it can cope with the demands of the sport later. Though the accelerated protocol was there in the 90s, but the failure rate was higher. So that's why we have gone back to the evidence-based protocol. It has to be very criteria-driven, and because of the understanding of tissue healing, load management has to be further. That's why as we go ahead, rehab post-op in the first week, decrease pain and swelling. POLIS and peace and love are the acronyms what we use for the decreased pain and swelling. CPM use, very controversial since no evidence of benefit from the CPM. So we are very still debating. If you use it, it's fine, but I don't think so. It makes much of a difference with the CPM. You can achieve the range of motion by doing active assisted and active range of motion exercises. Gain full range of motion of extension, basically. No hyperextension should be there, as I explained earlier also. Gain at least 90 degrees of flexion before leaving the hospital. Off of crutches and full bed bearing improves facilitation and VMO function. So once you start full bed bearing, your facilitation and VMO function definitely improves. Facilitation of VMO function improves. Week 1, correct get pattern. Checks for complications like DVT and infection. You have to check that. Exercises include ankle, AROM, flexion, SLRs, calf stretches, the normal exercises what you include in a post-op week 1. Do not put anything under the knee post-op, as lead to loss of terminal extension very quickly. So it is preferred not to put the towel roll for the static quadricep exercises below the heel or at the lower end of the thigh, but not rightly exactly below the knee. So the knee extension range is complete there. Note that if MCL involvement, then might splint knee in some degrees of flexion, but of course, it is determined by the surgeon. Early post-op up to 6 weeks, less hands-on, more direction with rehab. Soft tissue therapy can be introduced in this time. Push passive extension to reduce patellofemur and the notch problems. Extension extension apilateral glides seem to work best and is safe for the graft. Anteroposterior glides, okay, for the extension to achieve that. Open chain kinematic exercises could be introduced in this time. Definitely start with closed chain kinematics like 1/4 squats. Okay, the various ways you can use the soft tissue therapy for the quadriceps. Up to 6 weeks, we may need a gait re-education, hip and knee control. Exercise would include, as I said, active assisted range of motion, bike, high seat. We can do the half moon cycling for the range of motion, as I showed before. According to the available knee range of motion, loaded SLRs could be started, hamstring stretches, rectus femoris stretches, calf stretches, hip work, and proprioception. You can introduce the pool care with the walking in open chain kinematic exercises. Avoid open chain kinematic, especially 0 to 30 degrees and 45 degrees if there is effusion, if there is increase in effusion. You have to look for the signs of effusion for sure. Right, these are the various ways you can start loaded or closed chain exercises. Single leg squats with lateral tensions. Okay, not very loaded, and so on and so forth. You can progress. Okay, intermediate post-op up to 12 weeks. Continue to push extension, gain full range of motion. Continue the closed chain kinematic exercises. Progress to full squats pain-free. Start stationary running in pool. Exercises like passive range of stretching, gym, bike, low seat, leg press, leg curls, lunges, upper body work could be started in this phase. Running 8 to 12 weeks if no other intra-articular problem like swelling or pain, and have a good motor control. Proprioception training could be introduced during this phase. This is an example how do we introduce the running in the aquasizer. This is an initial way. This is the facility what we have at the Kokila Ben Ambani Hospital. We have the aquasizer because the water takes away the weight. It is easier for a patient to start with the partial weight for the running, for the high knees, various exercises we could do. We can gain the range of motion as well as the stabilization and the strength for the knee as we keep on progressing on those exercises, and ultimately a normal running pattern which could be introduced before you do the land running. So they really get used to the running in the water, and then you take them to the land for a better running better return to sport exercise or sport specific exercise. Late, that's the list post-op return to sport. I possibly we will do this tomorrow. Right, Doc?
Yeah, sure.
So
okay,
from this onwards, we can speak about it tomorrow.
Yeah.
Because it's been almost 60 minutes, and there have been, I guess, there are a few questions there.
Yeah, I think there are a few in the chat box.
Yeah, I'll just check them.
Yeah.
Can quads and hams muscle function rather than muscle size be an important factor in varied response of early? Sorry, I didn't get that question. What is she asking? Can quads and hams muscle function rather than muscle size be an important factor in varied response early after ACL injury? I'm sorry, Samnam, I'm not getting your question clearly. Could you please?
Yes, Sharma, can you unmute yourself and you can ask or
yes.
your question?
Yes, please. Shabnam? Shabnam?
If you're listening, you can rephrase your question.
Yes, sir. Hello.
Yes, Shabnam.
Yes, sir. So I'm asking that quads and ham muscle will be the important factor for the ACL reconstruction after the ACL injury.
Yes, of course, absolutely. It is going to be. It is not only quads and hams, but of course, even your hip musculature is going to be an important function. It is an important factor after an ACL injury. You're talking about after an ACL reconstruction done?
Yeah, after ACL injury.
Injury or reconstruction?
Injury.
Yeah, so after an ACL injury, of course, I mean, you mean to say why the ACL injury is happening because of imbalance in quads and hamstring tissue? Yes, it does. It does. I did answer that because it has been found out that if there is an imbalance between the quadriceps and hamstring muscle strength, okay, it's not about the size, it's about the strength. If the strength is imbalanced in between the two, the ratio is not proper, you definitely, if the quads are more stronger than the hamstrings, there are studies which are showing that because of the stronger quadriceps, the anterior translation of tibia is much more, and the ACL injury is prevalent or is very vulnerable in those kind of subjects.
Okay, sir. Thank you.
And Vaibhav, one question from my side.
Yes, sir.
Some of my patients, even after say 5 to 6 months post-op ACL reconstruction, and they show gross quadriceps atrophy. And they are unable to recover after that. And commonly these patients are definitely chronic ACL patient, say post 2 years injury or 3 years injury. And after doing reconstruction, they come with the same girth of their thigh, the wasted quadriceps after 5 to 6 months. Then what options do we have in those cases?
That's why doc, early function to get the quadriceps back using the EMS, electrical muscle stimulation with exercises, is a very good, has shown a good strong evidence in the literature these days. So if you're using an EMS with exercise, like a biofeedback, I mean, you get the current and you do the contraction of the quadriceps, helps to regain the control of the VMO as well as the quadriceps earlier.
Okay, so you suggest using EMS even in the early rehab?
Absolutely, in the early rehab, when the quadriceps function is lost, I mean, because we know that after post-operative, because of the post-operative swelling, the quadriceps is inhibited. Yeah. In those kind of settings where there is definitely a quadriceps lag which is going to happen. So as early as possible, if you can, of course, start doing the quadriceps contraction exercises also. But if you introduce the EMS, it has shown to have good results.
So can you tell us more about this EMS? Is it a like fixed setup machine or?
Yeah, it is basically electrical muscle stimulation, which usually every physio would use. Every physio would have that. And you use that. It's a EMS. I'll just get back onto those slides. Just a second. So for the voluntary contraction, that's what we were doing.
Yeah.
You see. So these are the two types of muscle where you place the electrodes on the quadricep muscle, and it's kind of a Faradic current which goes through. So
Yes.
when the current comes, when the patient feels the current, he starts to attempt to contract the quadricep muscle at the same time.
Mm-hmm.
So because of the electrical muscle, electrical muscle stimulation, and the active activeness of contraction of the quadriceps, telling the brain to contract the quadriceps when the current is passing through, it will give a good contraction, and that's what helps in re-education. So they get a biofeedback kind of a response, from not a kind of a response, but a biofeedback response from the electrical muscle stimulation machine, which is placed. The electrodes are placed exactly on the quadriceps through the skin. It will stimulate the quadricep fibers, and at the same time, if you tell your brain to contract the quadriceps, both in together will help. And it has found out to be so, combined with exercise, was more efficient than exercise alone.
Okay, great. And Vaibhav, we have Atharv. So every day Atharv asks a question,
Yeah.
because he himself is a strength and strength conditioning coach, and he has got a recurrent ACL injuries. He has
Acha.
got knock knees and hyperextension.
He himself has it.
Yeah.
Okay.
So we have already discussed that hyperextension makes you prone for repeated ACL injuries, and so he'd like to consult you also. So Athar, you can ask. Yeah, please. Athar, you can unmute
So,
yourself and you can, yeah, please. Yeah.
Yeah,
yeah,
Tharva.
hello. Yeah, sir. So even I am from Mumbai.
Yes.
I've been playing cricket for past 14 years,
Okay.
and now I've shifted my career to SNC.
Mm-hmm.
So I've been operated ACL thrice and medial meniscus twice.
Mm-hmm.
My question was, I have more hyperextension on my left knee, and I have more knock knee on my right knee.
Mm-hmm.
And the more prone to the injuries is my right knee.
Mm.
So that's what has led me to recurrent injuries. Even now, I'm suffering from a bit of ACL tear. So we have not gone through MRIs right now, but whenever I go to so being a SNC, and so I know the biomechanics, so the basic biomechanics. I have so when I was rehabbing, I've tried isometric, eccentric, and proper rehab. I've been through all that, but yet I faced this injury again.
Probably it's the neuromuscular control which is the issue in you.
The proprioceptors, the proprioceptors.
Yes, possibly.
Okay, because this
Possibly
keeps
because
happening because that keeps happening only in the medial region and the ACL, the medial meniscus and ACL. As my medial meniscus has been sutured and my ACL has been reconstructed, and even in the reconstruction, the graft which were taken were hamstring graft, Achilles tendon graft, and Patellar tendon graft.
Achilles tendon graft.
Yeah, they first took the Achilles tendon graft, but it fell short, and then they took the Patellar bone tendon graft.
Okay. Okay.
So I
See,
am surprised
see,
with this
there is.
Achilles tendon, what he's saying. So
Sorry.
I'm also surprised with the comment that Achilles graft has been used for ACL reconstruction.
Possibly they would have, because they might not have got the quadriceps tendon. I don't know, because they have used all the grafts for him, hamstring as well as bone, patella bone.
Yeah,
So
but Achilles is very rare.
yeah, it is very rare.
And peroneus longus can be used, and yeah. So whatever, yeah, please go ahead.
Yeah. So I mean, between hyperextension and knock knees, as you say, there is no clear evidence that a hyperextended knee or a knock knee, hyperextended, they are vulnerable. Even the knock knees, they are vulnerable because their valgus stresses can be easily put on them, and that stress leads to the mechanism of an ACL injury for sure. But you have to look at your proximal joint strength, proximal muscle, the hip muscle strength. You have to look at your core strength and your proprioception training, which is the most important neuromuscular training, which is the most important thing, I believe so. And probably that is the one which is lacking, and that probably you would not. That is the reason you're getting this recurrent stuff.
Because even I doubted the proprioceptors. So even I asked this to my doctor, but he said no, that's not the reason. But I didn't agree with him because from past I guess 5 to 6 months I've been training it eccentrically, isometrically. I've programmed this weekly design exercises. So being level 1 certified, and now I'm preparing for CACS as well with Amok Pandit sir.
Very good. Yeah, but
Yeah.
it basically has to be various reasons. It has to be assessed properly.
Okay.
It is not only because of your anatomical presentation, as you're saying, knock knees and hyperextension. It is not only because of that. Definitely,
Okay.
there are other factors to it, and we have to assess.
Okay. Got it.
Okay.
Yes, sir. Thank you.
All right. Latika, Shabnam asks again, leg extension exercise is beneficial or dangerous? Shabnam, as I explained in my presentation, leg extension exercise is the open chain kinematic exercises. The limited evidence which has come out of the literature has shown that if the open chain kinematic exercise is done in the range of 0 to 90 degrees, or in between that, actually, I wouldn't say even 0, somewhere in between 10 to 70 degrees, where there is not a full extension, there is no full flexion beyond 90 degrees, would be beneficial, and they are not dangerous. Anyways, even if you do it in 0 to 90 degrees, it is not dangerous. That the literature has shown. If I would go back to to my presentation and show you that slide where we talked about open chain versus closed chain, you will understand. That's where we have mentioned the aim of the study, which was basically carried out, was to determine whether open chain quadriceps exercise results in differences in anterior laxity compared to the closed chain. And the secondary aim was to determine whether there were any differences in strength, function, and quality of life. So they did do the study, but the conclusion was basically this. Okay, so there is no, it is not dangerous. It is not dangerous if it is done, but in a proper way, and with the whatever the evidence is available. Hope that answers your question. Latika asks, during proprioceptive training, using trampoline, landing on toes is preferable, or landing with full feet? Any precautions to be taken during trampoline proprioceptive training? Landing is soft. That is most important. It is not about landing, or you have to land on toes, you have to land on full feet. Both the kind of landings are done. Depends on what you are like. If you are, depends on what you're training for. Okay, so the trampoline, having your weight on the toes is always important. That's where you should land. The landing should be soft and controlled. That's why you do the trampoline training. Nothing more than that. It's so you have to before even you start your proprioceptive your plyometric training, your landing is more important than jumping or than doing the plyometric stuff. So you have to make them learn the landing technique. That is the most important. That is the challenge for anybody who starts training on the proprioceptive or the plyometric stuff, proprioceptive or plyometric stuff. Okay.
So I think we are done with the questions. Any further? Okay. So thanks a lot, Vaibhav, for your time and for elaborate demonstration of ACL rehab. And we will continue tomorrow with return to sports criteria. And I think we'll be discussing about the prevention also.
Little bit of prevention also. Yes,
Okay.
we do.
So shall we keep the time, Vaibhav, the same 6 to 7 or 5 to 6 would be fine with you? The way you want. We are comfortable with.
We can do 5 to 6 tomorrow. No problem.
Yeah. So guys, tomorrow we'll be meeting 5 to 6 and I'll send the intimation on the mails and everything. So thanks a lot, Vaibhav, again. And thank you both for being here. Thank you.
My pleasure, Doc. See you. Thank you. Thank you, everybody. See you all tomorrow.